So without further ado, it is my great pleasure to welcome our next guest, Olive Peart. Olive Peart, MSRT, is an established author, educator, and radiographer. She completed her Master of Science degree in Education at the University of Bridgeport, Connecticut, and is currently the program director with the Radiologic Technology program at Fortis College, Landover, Maryland. Peart has worked as a mammography and radiologic technologist for over 30 years and has lectured both nationally and internationally on mammography and radiologic related topics. Her published works have appeared in several radiology related magazines, as well as Radiologic Technology, the Journal of the American Society of Radiologic Technologists, or ASRT. In addition, Peart has authored several textbooks, including Mammography and Breast Imaging Prep, Long Q&A Mammography Examination, a Mammography Question and Answer Review book, and Radiographic Positioning Pocket Guide, to name a few. She has also created a mammography and breast imaging radiology flashcards. In 2004, she was awarded an ASRT Foundation grant and worked as a volunteer with the RAD-AID Asha Yoti Women's Healthcare Mobile Outreach Program in Chandigarh, India, where she taught mammographic anatomy, clinical skills, and quality control, among other tasks. In 2006, she was appointed Program Manager, RAD-AID India, and continued her volunteer work evaluating the sustainability of the project and identifying areas of concern. While continuing her work with RAD-AID India, Peart is also serving as a volunteer program manager, mammography technologist with RAD-AID USA Women's Health Access Initiative. The initiative started to address disparities in health rates from breast and cervical cancer among women of color in the United States. In her spare time, Peart enjoys reading and writing. She has written several young adult and adult fiction and nonfiction books. Welcome, Mrs. Peart, and the stage is all yours. Thank you.
Thank you for that welcome. Let me share my screen.
While Dr. Peart shares her screen, I just want to personally congratulate and welcome her for being a part of the speaking team today. Dr. Peart is the mother of a very dear friend of mine. She is repping Jamaica, as you can see her flag behind her. So welcome again, and I am taking myself off. The stage is yours.
Thank you. Again, thank you for having me on this program. I really appreciate it, the honor. And I will move right along in our theme, which is basically helping people to help themselves. Let's see. So what I'll cover today is definition of breast cancer, some cancer stats, anatomy of the breast, cancer risk, and some screening guidelines, updated screening guidelines on breast cancer. So what exactly is it? It is a disease or condition of the breast. Basically, the cells in your ducts or in your lobes can begin to grow, and it's an uncontrollable growth, which unfortunately eventually will leave the breast if not treated. So the earliest documentation of breast cancer was in 1600 BC. So it is not a new disease. However, now in this generation, we do have options. It is the second most common cause of cancer for women in the US, and it can occur in men, but it's not as common. Overall, since screening began in the 1980s, the survival rate of breast cancer in the United States has gone down. And screening, of course, is mammography screening, which is our early detection method. Some Caribbean stats, it has a high mortality. In the Caribbean, there's a higher mortality rate for breast cancer than even in US and in European countries. It's also the leading cause of cancer in 21 of the 23 Caribbean territories. And the Caribbean also suffers from a higher mortality rate even compared to Africa. In Dominica, between 2003 and 13, breast cancer was the leading cause of death among women. And this just graphically shows the stats. You can see Africa and the Caribbean, the mortality rate is at the extreme end. And then the interesting thing about it is that when you look at the incidence of breast cancer, the incidence is high actually in North America, Northern Europe, and Western Europe. Which means that what we need to focus on here is early detection and treatment to get the mortality, the death rate down in the Caribbean. So the areas of concern is here in US, approximately 42 women still die of breast cancer, and 1 in 8 will be diagnosed with invasive breast cancer. Black women in particular, and this addresses one of the reasons for the mortality in the Caribbean too, they tend to have a higher rate of death from breast cancer because some of the cancers discovered in Blacks, it's a type of triple negative breast cancer. This cancer, the treatment option for this has been limited in the past. It has been improving, which is good, but it tends to recur more, it tends to metastasize quicker, and it tends to have poor prognosis, which is why it is so important to discover these cancers earlier. And then we have the barriers. So discovering the cancers is not just the end. Once you get the cancer, there are sometimes both financial or personal barriers to getting the proper treatment. Sometimes there is not enough close screening sites, so women may not necessarily be able to easily go to a site. Transportation might be an issue. And then there's some who fear the technology. They don't want to hear any bad news. They fear the results. We also have a communication barrier. The doctor or physician needs to be able to communicate in a language that the patient can understand. There are cultural sensitivity needs that some patients has. There's trust between the patient and provider. A lot of patients might not necessarily have that trust. So not only do they not believe what the doctor is telling them, they may not necessarily follow the doctor's advice. They prefer to follow a friend who tells them, oh, you don't have to worry. There needs to be more collaboration between agencies, especially when the patient needs a follow-up. It's pointless getting a screening mammogram and then there's no follow-up. The treatment is what is important, and following up and following through on all of that treatment is also important. And then providing that initial financial support. Some patients may not have the money to even pay for a mammogram when it is not provided free. And then the transportation costs. So the key here is that we need to be actually promoting more screening, providing the education for the patients that they know what is important, and screening mammogram is definitely important for our well-being and reducing the sensitivity, reducing the mortality of breast cancer. Some of breast cancer factors that one breast can be bigger than another, and especially for women who have nursed. So the majority of women, the left breast is larger, and the difference in boob size can actually be up to 20%. One nipple can be varying in size also, and they can point in different directions. The key with your nipple is to make sure it could be inverted. It could be not inverted, but if there's changes or you start getting a bloody discharge, then that is something of concern and you need to visit your doctor and get that checked out. For breast cancer treatment, first thing to do when you go in, you have your mammogram. The breast cancer is not an emergency, so you may need to consult a secondary opinion. And then before you start any treatment, there are lots of treatment options. There's surgery, there's radiation, there's drugs. So doctors can treat any combination of these. The key, however, is that the treatment you have to really make sure you know the stage of the cancer, the type of cancer, the location of cancer. All of that information must be known before you go into treatment. Not that you can't change treatment midstream, but you don't want to waste time where you're treated for 6 months and you're being treated for the wrong type of breast cancer. And why I mention the wrong type is that there are different types of cancers that you can have. The cancer can also be localized in your breast. It could also have spread. Typically, they'll check your lymph nodes under your arm and find out, is the cancer there? If the cancer is there, then they know the possibilities the cancer may have spread into other areas of the body. So now you can't do just a localized treatment. You have to now consider treating the entire body. Type of cancer could be estrogen receptor positive cancer or negative, progesterone positive or negative, HER2 positive or negative. All of these are important factors because treatment of breast cancer is becoming so individualized. The treatment for HER2 positive breast cancer is not the same treatment that we get if you had a HER2 positive breast cancer. So all of these facts need to be known before any type of cancer treatment is started. Then the risk. There are no absolute risk. What this means is that you can have a risk factor, but that does not mean that you're going to automatically get breast cancer. You can minimize your risk because risks are divided into different categories. There are risks associated with lifestyle. So you can actually minimize your lifestyle risk. There are risks associated with genetics. Genetics risks might be harder to minimize, but at least if you know you have something in your genetics, then you can start being proactive in terms of getting diagnostic or treatment or screening mammogram as early as possible. So some of the risk. Age. Now, it's a myth that if you're cancer-free for 65 years, then you don't need a mammogram. That is absolutely not true. Cancer, based on research results, is actually, as you get older, the chances of you getting the cancer actually increases. Now, this does not mean that if you're in your 20s, you can ignore the fact that there's breast cancer. There have been diagnostic cases of breast cancer for women in their early 20s. So you do need to follow up, especially for women who have a genetic predisposition. They may carry the breast cancer gene. Then you possibly may need to check it early. Check your breasts early. Alcohol, does it increase your risk for breast cancer? Unfortunately, it does. Not that you should totally stop drinking, but alcohol, especially in high concentrations, it increases the circulation level of estrogen, and some cancers are estrogen receptor positive, which is basically you're feeding the cancers when you drink heavily. Antiperspirants. Should you use it? Should you not? Some people feel that they're using antiperspirants. It's going to give them breast cancer because the toxins are going to accumulate in your lymph nodes. That really is not true. Toxins are mainly eliminated by the kidneys, not through sweat. And antiperspirants basically is going to be, if it were absorbed in your armpit, then the cancer would develop right there because lymph drains out of the breast. It doesn't drain in, so it would take the cancer to someplace else in the body. But what we need to recognize that there are some chemicals that are what are called estrogen. They act in your body like estrogen. And for example, certain parabens, if you notice, if you go into the drugstore, you'll see antiperspirants or even face cream lotions that will say paraben free, because some of these things, they actually act in your body like estrogen. So once you use them, then you're basically feeding cancers which are estrogen receptor positive. Having ovarian, uterine, and colon cancer can increase your risk of developing breast cancer, and that is unfortunately true. It does increase your risk slightly. So again, if you have these conditions, then you know that you need to make sure you check your breasts regularly, possible as often as maybe once a year, even if you're under 50. Now, caffeine, does it increase breast cancer or the symptoms of fibrocystic disease? Fibrocystic disease is not a, or I shouldn't even say call it a disease. It's no longer recognized as a disease. It's a condition. Some people's breasts are very sensitive, and you find you touch your breast and it feels lumpy, have a lot of little nodes or cysts inside it. And that's a condition called fibrocystic condition where your breast tends to develop these. Sometimes it's all the time, sometimes only during the time when it's extra sensitive around your period time. But it is not associated with breast cancer. It can make detecting breast cancer on a routine screening mammogram more difficult, but there are lots of other options now. There's ultrasound, there's MRI. So this is the key is to communication. Again, you communicate with your doctor. You need to promote your own health. You know you have that condition, and you make sure your doctor is aware of it so that you can actually follow up and have possible other screening options or follow up with other diagnostic options. Exercise, will it lower your risk of breast cancer? And this is actually true. especially for young women, if you exercise regularly. So exercise overall, not just for breast cancer, just for overall health, keeping healthy, will substantially lower your risk of breast cancer. Physically active women had a 23% lower risk of breast cancer. So overall, exercise is good. And this is something follows on the theme of the other speakers, promoting your health. Immediate family history. So there's no cancer in your immediate family, so you can relax. I don't need to have a screening mammogram. I'm free and clear. Unfortunately, that's not true. The majority of people who actually get breast cancer actually have no family history at all. There's absolutely sometimes just no known risk, and you simply develop the condition. And we are living in a very polluted world. We're eating a lot of food, as we mentioned, the nutritionist just mentioned before. What we put in your body can have an effect on us, and I think we're absolutely polluting ourselves by putting a lot of chemicals in our body. So we don't know where this is coming from, but it is a fact that you can have no family history of breast cancer and you can develop the disease. And then just normal way aging, the process of aging, there might be a cell that malfunctions, and then you develop breast cancer, which is basically a cell that is not performing normally. It is overgrowing and uncontrollable and not limiting itself just to the area where it should be. Now, only your mother's family history can affect your breast cancer risk. You actually get genes from both your parents, half coming from your father, half coming from your mother. So even though you may not necessarily have a breast cancer risk on your mother's side of the family, and it may never have been expressed in your father, they may get something from their mother and it may pass down to you. So you can't just ignore it and say, no, nothing is in my family on my mother's side, therefore I can relax. Now, the myth of males not getting breast cancer. It is true that males tend to develop cancer at a lower, much lower rate than females, but they do get breast cancer. And one of the things that they've been noted and researched on is that it kills 25% of the men who develop it. And most often that is because they are not aware that they should be worried. They don't check it out. They feel something. They even have a discharge from their nipple, but they ignore it because they feel that it's not a disease for men. So speak to the men in your family, or men if you're listening. Yes, males can get breast cancer. Hormone therapy causes breast cancer. A lot of women now are not taking estrogen therapy because of the risk of breast cancer. That study that was done was actually on very, very high estrogen therapy levels that were administered. And they were done with both estrogen and progesterone included in this study. So recent studies have shown that lower estrogen levels and estrogen alone therapy may cause less risk for breast cancer. And the key here is, again, following up with your doctor. Your estrogen levels will vary from year to year. So if you are using estrogen therapy, the thing is to be properly monitored. Don't take too high a level. That isn't possible, unnecessary. Make sure it is based on what is your needs at the time. And there are also some herbal medicines that can help with the symptoms of perimenopause. Injury to the breast. Now, can trauma cause breast cancer? Oftentimes when you get a trauma, you may feel a lump in your breast and you go and check that out, and then you find that you have breast cancer. But the breast cancer was not actually related to the trauma. You went and checked your breast because you had that lump. So no, trauma does not cause breast cancer. Trauma can cause other things. It can damage the breast tissue, yes, but it does not lead to breast cancer. But you can have an associated cancer in your breast when you go checking for a trauma. Mammography is 100% accurate. Unfortunately, it is not. If you have a lump in your breast or you have significant issues with your breast and you go to a doctor and they say your mammogram is totally negative, you should not leave it at that. You need to take care of your own health. You need to follow up. There are other things that can be done. There's adjunctive screening, MRI, and ultrasound. Plus, there's interventional options that the doctor can actually go in and check to make sure that that area of concern is really negative, truly negative, and there's not enough cancer growing there. Because remember, breast cancer at its earliest stages is 100% curable. They take it out and you can live your life. It is when it metastasizes, leaves the breast, and spreads to other areas of the body, that's when it tends to cause a lot of problems. Now, menarche, onset of menarche, if it comes before age 12, is that increasing your risk of breast cancer? And it is true that early onset, more estrogen in your body for a longer period of time will increase your breast cancer risk. The same is true for late menopause. If it occurs later than normal, delayed over 3 increases your risk about 3% for the late menopause, and that is age 51 and over. And a painful lump, is it benign? A lot of time it is, but you cannot ignore it because you can have actually a cancer forming within the lump, which is called an intracystic carcinoma. So it's painful, you think it's normal, still check it out. Breastfeeding actually decreases your risk for breast cancer. Again, it's that lifetime estrogen that we're talking about. Anything that decreases it can potentially decrease your risk. So never having children can possibly increase your risk. Breastfeeding can lower your risk. And Black women get a more aggressive form of cancer, and white women have a high incidence of breast cancer. And we need to change this. We absolutely need to change this. This can be changed. The reason why more people of color, minorities are dying of breast cancer is because of the fact that the treatment may not be as effective if you're not diagnosed properly. There's poor planning, poor follow-up. So all of these are changeable facts that can result in a lower death rate among Blacks and minorities. So screening guidelines, again, start from age 40 to 45. That's when you should be screened. If you have a genetic risk or some predisposition, then you know you may need to check your doctor earlier. You should be having a mammogram every year or every other year. Again, this depends on what those genetic risk factors are. So again, check with your doctor and find out what your screening should actually be. Some of the things that if you may experience, you should check with your doctor: any type of family history of breast cancer, personal history of cancer, any other cancer. If you have any lumps, biopsies, augmentations, you need to check with your doctor, possible that may result in earlier screening. Any type of skin thickening, unusual lumps, dimpling, puckering, moles, eczemas, anything like that that remains, especially it doesn't clear up after a while, you need to check it out. And any type of abnormalities such as accessory breast tissue under the arm, accessory nipples, unusual nipple discharge, anything, check it out. Breast compression, unfortunately, the mammogram will compress your breasts. It's vital to have that compression because it actually not only reduces the radiation dose to your breast, but it helps separate the tissues, brings lesions closer that they can be easily identified. Some women have a severe problem with the compression, but there are things that you can do, especially scheduling it when it is less sensitive, your breast is less sensitive. If you need to use pain medication, consult your doctor. Caffeine, you need to avoid that for a whole month to have any appreciable effect. And also having the patient assume control, that is, some facilities may actually allow you to do that. So again, communication, that's the key. You may need to have additional imaging. Don't worry, that's them want to check and find out exactly what is wrong, especially if something is seen on the initial screening mammogram. And then the other imaging modalities that I mentioned, 3D mammogram, digital tomosynthesis, that is becoming more and more common. You can also have ultrasound, MRI screening, especially if you have dense breasts. These are something that you should speak to your doctor about. If you have anything, you must make sure you check it out and don't have them, a physician tell you, nope, everything is fine until everything is checked thoroughly. So an interesting fact, a good bra is hard to find, supportive, comfortable, always lifts you up, never lets you down or leaves you hanging, and is always close to your heart. So thank you very much for giving me this opportunity. I hope I was able to help someone. I'm not sure if there's any comments. Let me check.
Thank you, Olive. This was very informative. I think sometimes we forget how important breast health is for women and men. Even if men, get at a lesser rate than women, it is very important for men and women to really make sure that they are very aware of their breast health, and just making sure when they do go to the doctors, they are their own advocates and they ask questions. And as you said, if we get one diagnosis, we don't take it at there, but we get another and we get a second opinion. So now